Good day, ladies and gentlemen. We are on the sidelines of the first World Congress on Cardiometabolic Disorders. And indeed, it's a privilege to play host to Dr. Pradeep Chaubey. Welcome, Dr. Chaubey.
Thank you very much.
Dr. Chaubey is a renowned bariatric surgeon, and he is chairman of Minimal Access Bariatric and Metabolic Surgery at the Max Super Speciality Hospital in Delhi. Dr. Chaubey, we've been hearing of bariatric surgery for a long time, and typically it has been associated as having only cosmetic connotations. So does the benefits of bariatric surgery extend beyond cosmesis?
Yes, I think bariatric surgery in a true sense is a life-saving operation, and it is done for a particular cause and not in overweight or obese patients, but in morbidly obese patients. That means their body mass index is more than 37.5. If those patients happen to have diabetes and other metabolic issues, then the BMI reduces to 32.5. So, if we say by and large, if the person is about 30 to 40 kilogram extra more than what his normal weight should be and is having diabetes, which is not really controlled well with the medicines and other modalities and lifestyle changes, then bariatric intervention is considered as life-saving, and it not only reduces the weight, but also the diabetes, hypertension, dyslipidemia, etc. are benefited to the extent of diabetes actually going into remission in that manner, the hypertension reducing, and of course the psychological effect of well-being and also the anxiety and self-esteem really goes up.
Now, what's the mechanism of action of bariatric surgery, if I can ask you a very basic question?
I think most of the bariatric surgeries are aimed in excluding the stomach, duodenum and first part of the small intestine from the passage of the food. So, when the food passes, when the food does not pass through the stomach and first part of duodenum and goes into the second part of small intestine, that makes some endocrine changes and also reduces the fat absorption and changes the metabolic condition of that particular person. So, it is the exclusion, not allowing the food to go into the first part of intestine, going into the next part of the intestine.
So, does that, as a corollary, does that lead to some kind of nutritional deficiencies or certain essential nutrients not being absorbed?
Well, I think there are a lot of confusions about the word bypass. I am talking about the gastric bypass. There are many conditions like biliopancreatic bypass and duodenojejunal bypass, and those bypasses we are not considering for Indian patients.
Sure.
Because those are they need a very high protein diet, and our Indian diet is mainly a high carbohydrate diet. So, when I am talking about a gastric bypass. The commonest deficiency which we have seen after gastric bypass is a vitamin B12 deficiency, which, as everybody knows, is very simple and easy to take. All these patients are supposed to be taking supplements like calcium, iron, B complex, because we make the stomach small and all these things are absorbed in the first part of intestine. So, if these patients simply take a tablet of calcium, iron and B complex, I do not think there is an issue of any malabsorption, and I am very particular that it does not produce a protein malabsorption.
Okay. So, only micronutrients may be deficient, which can be easily replaced.
Correct. Yeah.
Is there any other downside in terms of, we hear an occasional sensationalizing report of pulmonary embolism and those kind of things?
Yes, I think all operations done for any obese person, whether it is a bariatric surgery or a cardiac surgery or a renal surgery, will have a higher risk, because the obese persons, they belong to ASA grade 3 risk. So, that is there. But I think whatever news we hear, most of the news are not from the centers of excellence.
Okay.
This is a surgery like a cardiac surgery and other super specialized surgery should be done by a team who is expert with multimodality. I think you have to have a very good team of anesthetists, the nursing staff, the technical staff and support staff for that matter. Like any cardiac surgery, it needs a lifelong support system to be provided to these patients as and when it is necessary. So, patients should choose centers of excellence to undergo. I think they should not really be going to the occasional centers and smaller centers where this is not the main thrust of their specialty.
Is there any major learning curve to learning this procedure as far as the doctor and the surgeon is concerned?
Definitely, I think there is a fairly long learning curve. And
would you like to put any number to the learning
generally
curve?
we
How
say
many
about
cases?
50 cases.
50 cases.
Cases to be seen and to be witnessed with the experts, because there too much of a technicality involved. The centers should be equipped not with the surgical equipments, but even the toilet seats, even the chairs, because these patients are maybe 200 kilograms.
Yeah.
So, when those things, so any center of excellence will take care of all those issues. The anesthetist should be trained for bariatric anesthesia. It's an entirely different super specialty and a different ball game.
Now, in results, do we have any data on outcomes in terms of hardcore survival benefit, or is it only reducing the amount of medicines, reducing the weight, the BMI, but is there any survival advantage?
I think there is a very good trial done in Sweden, and it has proved 84% survival benefit. So, what they did was they divided the patients who were morbidly obese and simply they asked them whether they want surgery or they want and 20 years later they tried to look at those same, as you know, Sweden being a small country. So, they tried to look at those patients and 84% of the patients who did not have surgery were not living 20 years later.
Is there any failure rate to this surgery?
Yes, I think failure rate mostly is related with the compliance. If the patient is not compliant, and we see alcohol as one of the biggest cause for failure, and lack of physical activity and reluctant to change lifestyle because you have to change lifestyle keeping it in mind. Alcohol being empty calorie does not really work because there is no restriction for liquids.
And is there any follow-up protocol or any message you want to give to the physicians and the family physicians who are going to see these patients as to what is the follow-up that they should insist on?
Well, I think the follow-ups could be very in a very simplified manner. We should say how much calorie is going in, and the calories should be high protein, less of carbohydrate, and the supplements, which are actually very simple supplements like calcium, iron, B complex. It does not really matter. And third is every year checkup, as we say, the biochemical checkup, which is again not complex. It's a simple vitamin B, vitamin B12 and protein contents, etc. So, we have seen that any patient who is doing every year checkup, most of these checkups we find that if there is a small little deviation can be corrected.
Is there any need at times on a follow-up where you would take the patient for takedown of the bariatric surgery?
Well, I think it's very, very rare. So, couple of thousand, maybe I think maybe 1 in or 10,000 operations which needs to be reversed because of hypoglycemic episodes, dumping syndrome, but it's very rare. And if the patients take protein intake, it can very easily be prevented in almost all the cases.
So, ladies and gentlemen, you just heard Dr. Pradeep Chaubey, a renowned ultimate name in the field, bats very strongly, but then he is very clear and candid that it should be done at recognized center by well experienced people, and if done well, it has hard benefits in terms of survival advantage. Thanks a lot, Dr. Chaubey.
Thank you, Abhi.
Pleasure having
It's
you.
always a pleasure. Always a pleasure.